Good morning from India. This is Dr. Rutledge, and I'm honored to be here. This is a preliminary presentation of my planned presentation for the society meeting in Poland. So hope you'll find this useful, and I'm happy to take any comments or criticisms. So we'll go ahead and share my screen, and we'll get started with today's presentation. Mini gastric bypass, the present and the future, good MGB, bad MGB. So we'll talk a little bit about that this morning. Before I begin, I'd like to thank everyone who has fought with me over the past 25 years to get the mini gastric bypass recognized around the world. And so it's pretty exciting for me since the first MGB was done in 1997. And surgeons around the world for 25 years have been saying it's a bad surgery and I'm a bad surgeon. And it's nice to realize that most of the rest of the world now does not think that anymore. I say most, but not all. There's a famous quote. It says, with great power comes great responsibility. And I think both of those things are important for the MGB. And I'll talk a little bit about the power of the MGB, but also the responsibility of doing it well as opposed to doing it poorly. The MGB has great power, but it also gives a tremendous responsibility as well. And so that's what we're going to talk a little bit about today to give you some tips and pointers in that area. So these are topics for questions, and we can come back to this, but obesity and addiction, salt, sugar, and fat as far as dietary components, the MGB diet, there's some unique features that are different than many surgeons kind of understand. Supplements, follow-up blood tests, the data from 25 years after the first MGBs. Marginal ulcers, gastritis, it's not really acid that causes that problem. There's a lot of misunderstanding of that. Fainting and salt. Deficiencies such as excessive weight loss, it's not the biliopancreatic limb length. Gastroesophageal reflux disease, bile reflux, gastritis, and ulcers are topics of conversation. Estrogen and depression, osteoporosis, and anemia, all are good topics which we could discuss depending on the group. And so come with me if you want to live. This is Arnold Schwarzenegger reaching out to say, come, we have the answer. And so today I hope I'll give you a good answer. And so what I'd like to say is everything that I talk to surgeons about is often wrong, especially if you are a sleeve or Roux-en-Y surgeon where the components and the primary dictates of sleeve and Roux-en-Y are not what we do for the MGB. So there's some significant differences. And with this understanding comes a lot of power and safety. I volunteer to talk to anyone around the world if you have troubles. I'm flattered to get calls from Iraq, Iran, India, all of Europe, and would be happy to entertain phone calls and discussions about any of these practices that I'm going to talk about this morning if you consider adopting the MGB. Now, I want to point out a few things as far as the bad MGB. If you look in the literature, there's some really bad outcomes. This is the French series that had 16% had gastrojejunostomy strictures. Well, that's terrible. Here's another study. This is looking at the results of MGB in India, and this was several 100,000 patients in 2019, and the weight regain at 5 years was least in patients who had the MGB, 3% compared to 35% in sleeve, so 10 times less, and much better significantly than Roux-en-Y. So now we have good and bad, and we'll do that a little bit more. The MGB is just something I came up with in September 1997, and I thought we want to hear this, and we'll talk a little bit about that. So what am I going to talk to you about today? We'll tell you some things you don't know, tell you some things that are from the future, clear up some confusing things, and maybe some things that you already think are wrong are actually right. So here's the history. And basically, for 20 years, I was a trauma surgeon at the University of North Carolina. And 1997, a drug dealer came in. He was shot in the abdomen 6 times with a high-powered handgun. About 9 o'clock on a Thursday night in September 1997, I took him to surgery and identified abdominal wounds to the stomach, the tail of the pancreas, and the spleen, as well as other body parts, which are not relevant to today's conversation. The injury, as I said, to the stomach and pancreas are important for this discussion. And so we did a distal gastrectomy, a distal pancreatectomy, and splenectomy, a few other things, repairing aneurysms. And that was the end of it. And we had to reconstruct the gastrointestinal tract, which we did through a standard general surgical procedure, which was an antrectomy, essentially, with a distal pancreatectomy, a splenectomy, and a Billroth 2 gastrojejunostomy. This is general surgery for more than 100 years. There's nothing new about it, although when I did it for obesity, surgeons around the world got frightened for 25 years. So it's an unusual and maybe somewhat amusing story, except for the fact that I was the butt of jokes and criticism for 25 years for doing something that we've been doing for over 100 years. This is the next morning. I planned a laparoscopic Roux-en-Y gastric bypass, which in 1997 was rather challenging. And so instead, I did what I had done last night in the operating room for a trauma patient, and I did a collis gastroplasty and a Billroth 2 gastrojejunostomy. The operation was short and simple compared to a Roux-en-Y at that time, and I violated a variety of other ideas at that time. So, but the MGB paradox is kind of resolving itself. The ASMBS has just endorsed the MGB now 25 years later. And in some ways, I can think maybe my work is done, but no, not quite. And I'll talk to you about some of those issues. I'm going to talk to you about what I call is the MGB paradox. And what I mean by this is some surgeons, including myself, report excellent results, while some surgeons, like the Y-omega trial, a French study, and in 2021, a study from Australia, report terrible outcomes. And that's kind of an unusual situation. So again, here's the MGB paradox I want to talk to you as a group this morning and maybe answer questions about it. Is there are hundreds of articles and tens of thousands of patients showing that the MGB using my original technique has excellent outcomes, whereas there are occasional worldwide reports of poor weight loss, excessive weight loss, bile reflux, leaks, and even death. And so what is going on here? How can we explain it? And how can you avoid the bad and give your patients good? So here's an example from Dr. Lee in Taiwan, so halfway around the earth, who had, looking at his patients who had failed primary weight loss surgery, and they reconstructed the patients with either an MGB or Roux-en-Y, which both are kind of similar in some ways, but the MGB was more than twice as good when compared by % excess weight loss. So example of good MGB. On the other hand, here's a study from France, and we've seen studies like this where the bile reflux is reported up to 1 in 3. So again, good MGB, bad MGB. Here's a study from the Y-omega trial. 20% of MGB patients had gastritis and esophagitis, 20% had diarrhea, and up to 20% had to have reoperation within the first year. Unbelievably bad results. In fact, the country of France stopped MGB surgery. Again, bad MGB. What's the paradox here? Well, these are my possible explanations. The surgical procedure itself is flawed. The surgeon's technique could be at issue, or postoperative management. And I'm going to argue it's not the first, and probably 2 and 3 are more likely. So the gastrojejunostomy is an example of, I'd like to give you a quick look at the difference between good MGB, bad MGB. And misunderstanding leads to mismanagement and bad MGB. And if you look online, you can watch videos of many surgeons doing what's called the 1 anastomosis gastric bypass now in many of the literature instead of MGB. And you can see what I would declare are very bad versions of my MGB. So let's talk about the gastrojejunostomy. That's the connection between the stomach and the small intestine, and just demonstrate bad MGB and good MGB. And just think about what you know as general surgeons. What makes a bad enteral anastomosis? Well, if it's devascularized, if it includes foreign body or foreign bodies, if it's twisted or kinked or has tension, all of these you know are bad. Now let's apply that to good MGB, bad MGB. So here's a schematic drawing of, say, the distal tip of the gastric pouch in an MGB, and we'd like to show you some things here. So when we staple this, this becomes the neo greater curvature, and there's obviously no more gastroepiploic vascular supply here. So this is now no longer a source of blood supply. We know that our blood supply is now by the lesser curvature of the stomach, and that's the left and right gastric arteries. We know that if we have a staple line here or here, we can vary in our ability to provide blood in this area. So if we go here, then we get blood supply here and potential collateral here. As we move laterally here, now this becomes an avascular plane, this becomes avascular, and so then we have dead tissue here with a large amount of titanium foreign bodies. And so that is likely to lead to stricture, ischemia, foreign body reaction, ulcer, gastritis, and bile reflux. So let's look at that in some live studies. Here's an example. So remember now we're looking at this. We're talking about the dashed lines are foreign body and no blood supply. So here's the neo-greater curvature. Here's the staple gun stapling to small intestine. And also notice here that the dissection by the surgeon has taken away this distal blood supply. So now all of this tip, maybe 4 to 5 centimeters in every direction, is avascular. So you're doing an anastomosis which has low blood supply. In fact, you could say no blood supply. And when that happens, foreign body and no blood supply, then we have, as we say, increased risk of reflux, marginal ulcer, malnutrition, lateral aspect. All those bad MGB things that we talked about here come from mismanagement by the surgeon. Now, there's lots more tips and tricks, but that's just one example. Here's another example. What we like is the stomach, lesser curvature here and greater curvature here. That's the right way the stomach to lie. Look at this. We have a corkscrew pattern, a twisting. This will be partially obstructed. Probably there's a significant ischemia here. So this is a bad MGB. Here's another extreme. You notice almost 180-degree turn, bad MGB, the twisted pouch. Okay. What we say is it's a good operation, but it's a good operation in the right hands. And so the MGB has positives if it's done well. And here are some of the positives. Can be tailored to meet all needs. And we'll talk about this. The usual bariatric patient, plus or minus diabetic, is a good candidate for the MGB. The super obese patient is a good idea because we can tailor the BP limb, which we'll talk about a little bit if there are questions. It's good for the GERD patient because the MGB reduces the lower esophageal sphincter into the abdomen by tension from the attached gastric to small bowel anastomosis. It's good for the difficult patient and the borderline patient because it's so easily reversed. So if someone needs it, you can try it. God forbid you have to undo it, it's easily undone. In addition, you can do it for non-obese diabetics by shortening it to a basic general surgical Billroth 2. Here's normal anatomy. Here's the gastrojejunostomy. And so now remember your general surgery for some keys to MGB: a long pouch, a wide gastric pouch, no dissection of the EG junction, a moderate BP limb, not short like the Roux-en-Y, not long like the Sadi, wide open, non-twisted gastrojejunostomy as we looked at it, and the mechanisms are worth talking about if you ask me questions later about what's called the post-gastrectomy syndromes. Here's a quick look. This is dissection of the lesser curvature. Staple gun perpendicular to the lesser curvature, sparing the blood vessels. And then we begin tailoring. There is the pouch, and we can talk about the wide base and avoiding the EG junction. That's the staple line, gastrojejunostomy, and repair. And so it's simple, elegant. It's a same-day surgery. It can often be done in 15 to 60 minutes. It's one of the most effective operations. It's durable now for more than 25 years. It's powerful. It can be tailored to the thin patient who has a metabolic disease as well as to the super obese, and it's reversible and easily revisable. Again, simple same-day surgery, elegant, effective, durable, powerful, reversible, revisable, and tailored to the thin diabetic. Imagine the overwhelming epidemic of diabetes in countries around the world, and imagine that a 60-minute procedure could treat that and reverse it in many cases. In our series, up to 10 or 15 years afterwards. And again, non-obese diabetics we think is worth discussing today if you have questions. The Billroth-2 has been shown to treat type 2 diabetics in numerous studies, and it may be the ideal treatment, in my opinion, for thin diabetics who are suffering from the complications of diabetes. That's my presentation. I hope you enjoyed it, and I'd be happy to answer any questions.